Welcome to the 21st. I'm Nyla Boodoo. We know that with certain medical conditions, timing is crucial. Take a stroke. If it's not diagnosed and treated within hours, patients can have very different results. Today on the 21st, we're talking about how telemedicine, that's a catch-all term for virtual connections patients can make with doctors, is changing this issue. We're going to talk about how patients at small hospitals are using telemedicine to link with specialists all over the country and how it's helping rural healthcare across Illinois. Let's start with Bob Denton, who suffered a stroke in 2014. He lives 100 miles away from a neurologist in Springfield, but was able to get a near immediate assessment of his condition thanks to the telestroke program at St. John's Hospital in Springfield, which is where he's joining us right now from the doctor's office. Hey, Bob, welcome to the 21st. Thanks for being with us.
Hi, Nyla. Thank you.
I wonder, Bob, if you can walk us through the day you had your stroke back in October 2014. I know you woke up and you took a shower, but then as you were getting dressed, something didn't feel right. What happened?
I couldn't make my right arm move like I wanted. I got back to the table, but I was knocking the chairs over trying to sit down, and that woke my wife up. And that's kind of how they found me.
And I know that then the ambulance then took you to St. Anthony's Memorial Hospital in Effingham. Is that just a few minutes away from your house?
Yes, I'm only 5 miles from Effingham.
But I know you needed to speak with what you needed was a neurologist who's based in Springfield. So just for everyone knowing the distance there, that's 100 miles away. Now, instead of driving, the healthcare team wheeled in what's called a telestroke robot, so you could speak face-to-face with the doctor through the computer screen. Do you remember what that was like?
Oh, I could see him, and he could see me, and he would instruct him to turn it different directions so he could see what I looked like. And by that time, I was getting my vision back in my right eye and my feeling back in my right arm. But I think he could get a better vision on what was happening to me at the time.
And was he asking you do you remember if he was asking you, I guess he was probably asking you specific questions, like just to try to gauge what your condition was?
Yes, he asked me several questions. They were going to use a new medicine, but I had some work done before, and they couldn't use it, so they had to revert to something else.
And they started treating you immediately, and I know this was back in 2014. Bob, how's your recovery been since then?
It's great. I do whatever I want to do. The only problems I have now is short-term memory.
Bob, we really appreciate you coming on and sharing your story. Thank you so much for being with us.
Okay. Thank you for having me.
I wanted to bring two more people into the conversation. On the line from Springfield is Dr. Gurpreet Mander. He's the Chief Medical Officer at St. John's Hospital in Springfield, where, as you just heard Bob he's chair of the Illinois Telehealth Network. He oversees a telemedicine program that helped connect Bob in Effingham with that neurologist in Springfield 100 miles away. Dr. Mander, thanks for being with us on the 21st.
Good morning, Mel. Thanks for having me on.
Also with us on the line from Chicago is Nancy Kasek, director of the Illinois Telehealth Initiative. Nancy, welcome to the 21st as well.
Thank you so much. I'm glad to be here.
Dr. Mander, we just heard Bob share his story. There was that 100 miles would have been hours, obviously, before he could have been seen by a neurologist. Dr. Mander, can you help us understand why, with a stroke in particular, an immediate evaluation by a neurologist is so critical?
Yeah, I definitely can. So, strokes are pretty large public health problem in the United States, and there is a difference or a discrepancy between the care we give patients with stroke versus what the standard of care is. And the main reason behind that is an immediate access to specialists who can diagnose, evaluate, and initiate treatment. So, the American Heart Association has actually approved the use of telemedicine in stroke. Time is brain. So if it's not treated in a timely fashion, your brain cells start dying and get injured. So, and the earlier you intervene, the better the chances of recovery. So that's the reason we need to treat that immediately.
Mm-hmm. And how long has this telemedicine, this telestroke program, been in existence for you all at St. John's?
It's a little above 2.5 years.
And how many hospitals are you connected with throughout
We
Illinois?
are connected with 12 regional sites through our hub site, which is St. John's Hospital, HSHS St. John's Hospital in Springfield.
Mm-hmm. And is it literally how we were describing it with Bob's experience, where you
It
just
is.
roll a screen out, I guess?
Definitely. The way that works is that if a patient presents in one of our rural emergency rooms with symptoms of stroke, they call our 1-800 line, which is our access line, and initiate the stroke protocol. And within about 10 to 15 minutes, the robot is activated, and a neurologist is able to evaluate the patient. They walk you through certain examination. They talk to you, make you move your arms, legs, and then with the help of the local physician or the nurse, they complete an examination. They're able to review the CAT scans, which have already been done and ordered as per standardized protocols, and review the patient's history, and then come up with a treatment plan in a timely fashion.
So there's also obviously an admitting physician or a nurse who's physically in the room with the patient as the doctor remotely is also going through things.
Correct. It's a local emergency room physician usually with the help of the local nursing staff.
And as you mentioned, stroke is the third leading cause of death. And I know that there's been systematic reviews of studies that have found these telestroke services have reduced mortality. And as you said, it's been approved by the AMA. I imagine some people, though, might be thinking, is this as good as an in-person visit? What's your response to that?
It is. I think, in fact, one of the most mature programs in telehealth and telemedicine is stroke. It's been in existence for a long time, and there are large studies both out of Europe, Canada, and the U.S., which support that early access and a timely evaluation by a neurologist leads to the same outcomes as in-person examination. And probably a more important thing is the risk of complications by the use of the clot-busting medication. That's also the same as in-person versus telemedicine. So, it has helped save lives, also helped us with timely initiation of the clot-busting medication, TPA, and or, if need, referral for an intervention. And it has been shown to improve long-term outcomes, neurological outcomes, and decrease institutionalization. So.
That's Dr. Gurpreet Mander. He's the Chief Medical Officer at St. John's Hospital in Springfield. He's chair of the Illinois Telehealth Network. We're talking about telemedicine right now on the 21st and how it's particularly helping rural healthcare across Illinois. If you have questions or comments, as always, you can join us. Our phone number is 1-800-222-9455. That's 1-800-222-9455. You can tweet to 21st Show, 21ST Show. And on the line with us as well from Chicago is Nancy Kasek, Director of the Illinois Telehealth Initiative. Nancy, as we're listening to this particular way that telemedicine is being used, I wonder if you can take a step back and define for us what exactly we mean when we say telemedicine. That's a very specific program, but I imagine there's lots of other ways hospitals and patients and doctors are using this.
Absolutely. The easiest way for me to describe is that it's a way of connecting providers to patients and providers to other providers using telecommunications. And so it could be everything from interactive video, it could be computer connections, it could be monitoring devices. It's just taking advantage of technology to cut the time down, in terms of providing care, improve the access to care, and also reduce cost of care, which is obviously a big issue not only for patients but for health systems.
Mm-hmm. And how else are people using telemedicine then?
Nationally, it's spectacular what they're doing. But in Illinois, the things that have sort of jumped out at me as being particularly great are not only the great work of the HSHS system and other telestroke networks, but also in mental health. Mental health is a prime example of where you could provide easy mental health care. So, a child is having an incident at school. The school says you should go to the community mental health clinic. By and large, the kids never make it to the mental health clinic. And in many states...
Why is that?
Because of the intimidation, the stigma of going to a community mental health clinic, the delay in getting access to a mental health provider there, and just, sort of kids are kids, right? And they don't do things right away, and the situation, the urgency changes after, time passes, and they don't make it there. But in other states, they have, like right next to the nurse's station, they'll have a room there with no label on the door or anything, but it's just a room where they can go in and talk to somebody to provide mental health care. care via interactive video, and right then and there. And it's spectacular. And kids around the state, but particularly in rural communities, need access to mental health providers. And 90% of the state of Illinois is a mental health provider deficiency area. So we have to be able to figure out ways of doing this. Sometimes what happens now is if a child is told that they need to see a child psychiatrist are pretty much in the Chicago area. I mean, probably 95% of them are in the Chicago area. If you're downstate, what it means is that the child needs to take a day off from school, parent needs to take a day off from work, and then they need to travel to the city of Chicago, where they go into an office where the child is intimidated by not being in his comfortable space or her comfortable space, and they don't open up as much. But it has been proven around the country that what happens in all sorts of studies is that if you provide telemental health care in a secure setting, in a prompt setting for the child, they open up. They love talking to a doc in a box. That's what they're used to, having interactions, with interactive video on their phones and on their computers, and they're used to it, and they open up like wonderfully, and you don't have the time delay and the cost that involved with it.
Nancy, I know under former Governor Quinn, you were in charge of the Illinois Governor's Telehealth Working Group. I wonder, from your perspective with that, as well as now with your work with the Telehealth Initiative, how do you think Illinois ranks compared to other states when on accessing this and providing telemedicine?
Well, I can tell you this: Illinois is not a leader. In spite of the spectacular things that Dr. Martyr and Dr. Brockhaus at Carl Foundation are doing and other people are doing in the state, we're not a leader in this.
And why?
Well, it took me 5 or 6 years to figure this out. I couldn't figure it out at first, but finally what happened is I realized that it's the highly competitive healthcare market. Healthcare systems right now are fighting for the last dollar. They don't want to take any risks, and they're going through a lot of transition. But what you can see is that states around the United States are just blossoming in their use of telehealth. And Illinois is, I think, really waking up to it right now.
Well, and one other question, and Dr. Mander, I want to bring you back into this conversation about the competitive stuff. But before we get to that, Nancy, I know 21 states require private insurers to cover video visits. Is Illinois one of them?
No. It is not. It's one of the 13 states where there's no mandatory requirement, nor is there any practice. In some states, they don't even need to pass a state law that requires that there be reimbursement because the insurers say, this makes sense.
Do we need to pass a law here, then, for this to happen in Illinois?
Well, that's an issue. I mean, it's the issue as to how you set this up, but it certainly should be part of the conversation. I mean, the big issue we have in Illinois is that at this time, the primary insurance company that dominates the healthcare market is Blue Cross Blue Shield of Illinois, and they do not have a practice of reimbursing for telehealth. But there are other new insurers coming in. Cigna, and I heard Anthem from Indiana is going to be coming into Illinois when they purchase Cigna, Aetna, United Health. They're all reimbursing for telehealth in various ways. Medicare reimburses for it in rural communities, and Medicaid reimburses for it right now.
Oh, okay. Well, I think that explains a lot for people. Dr. Mander, what about to Nancy's point about the competitive nature? Because as we said, your telehealth program at St. John's in Springfield, you're working with more than 20 hospitals all across the state, and you're connecting people. How did you convince competitor hospitals to come on board and collaborate with you guys?
I think that's a great question. I think just to follow up on Nancy's points, the lack of parity in payment is definitely a big barrier in implementing telehealth across Illinois, and there are some bills which have gone back and forth in front of the local state legislator, and we need all the advocacy we can to support that effort, because I think that'll be a big game changer once we're able to reimburse providers and hospitals and entities to provide these services. Now, what we are doing through the Illinois Telehealth Network is actually in parallel with our HSHS telemedicine initiatives. We felt that when we got into this about several years ago, we noticed that there was a lack of knowledge among various hospitals, and and individuals, and also there was a lack of resources to invest in, especially with the smaller rural hospitals, the critical access hospitals. So our thought was that maybe can we bring people together? Can we bring different organizations, our own hospitals, plus hospitals who might be with competitors for the common good? and to work on a common cause and look at telemedicine as a shared resource with the greater good in mind. Given that we serve a rural population, we most of our hospitals in the region are in health shortage areas where there's lack of providers and specialists. So with that in mind, we went forth and got the concept of the Illinois Telehealth Network. The best way to put it was just old-fashioned communication and relationships which we had built up with our regional hospitals through our transfer center by providing services over the years. We just reached out to them, to their CEOs and the leaders, discussed the concept, and we brought everybody together.
So, Dr. Mender, I'm going to stop you there because we're going to have to take a break. But when we come back, we're going to continue this conversation. I want to find out a little bit more about that. And we're also going to be joined by Carle Hospital as well. So stay tuned. We're talking about telemedicine here on the 21st.
The 21st is made possible by the library at the University of Illinois at Urbana-Champaign, fostering discovery by providing information curation and archival services to extend scholarly impact from Urbana-Champaign to the state, the nation, and the world. The University Library at Illinois.
Welcome to the 21st. Welcome back. I'm Nyla Boodoo. We've been talking about telemedicine and some of the ways it can improve access and cut costs, especially in rural areas across the state. Stefan Robinson is on the line with us from Madison, Illinois. He's the former director of the telehealth program at UIC Hospital. Stefan, welcome to the 21st.
Thank you for having me.
Now, you have many years' experience working in telemedicine, but the larger reason we wanted to have you on the show today is about 6 months ago, you suffered a stroke. Can you tell us what happened?
Well, I'm an athlete, and I'm actually 50 years old this year, but I'm an athlete, and was playing a basketball game. After that game, I suffered a stroke and presented at one of the local hospitals here, and just did not receive adequate care, essentially, for the condition. And certainly if there had been access to telestroke services, to reach out to one of the tertiary care centers, then certainly I think the outcomes would have been better.
And I understand your wife was with you at the ER, was speaking to the hospital staff, saying because it wasn't clear to the staff or they didn't believe that you were having a stroke?
Right.
Now,
So
go ahead.
there's a protocol that's FAST, and unfortunately, because of my stroke, I don't remember what the acronym stands for, but FAST, the protocol needs to be it needs to be applied at the time the patient's there, and a decision made as to whether or not the patient should be moved to a stroke center, and it just didn't happen in my case, and so and it was just an unfortunate situation.
And just to be clear, you were in Chicago at this point, right?
No, I play in the southern suburbs of Chicago, so around, I believe that hospital. Well, it's near Madison, Illinois.
Okay, so you were in the hospital, so it was southern suburbs. And
yeah.
Earlier in the show, we spoke to another stroke patient, and he lives in Effingham. But because of the telemedicine program, he was able to get an assessment by a neurologist immediately. At what point were you able to see a neurologist? Because there wasn't one on site at your hospital. When were you finally able to see one?
About 12 hours later. There is a neurologist that arrived around 11 a.m. I actually arrived at the hospital that night at 10:30 p.m., and so I saw a neurologist the next day around 11 a.m.
Mm-hmm. And how has your recovery been?
So the challenges with stroke is after a period of time, and I believe that amount of time is 3 hours, 3.5 hours, something like that, or 4 hours, where they have an opportunity to intervene and provide some type of a clot-busting drug or try to alleviate the clot. And, so that didn't happen. Can you repeat the question once more for me?
Well, I just was wondering in terms of your symptoms, how that's sort of affected how it's affected your life right now.
Okay, so in terms of the way it's affected my life, it's really more memory based, and so having had the stroke, I forget things quickly. after that fourth hour or so, whatever you've experienced at that time is, I believe, what you've got going forward. And so for a lot of people, that's paralysis, and that's certainly something that I had early on. Drooping mouth and inability to see from one side of your face or the eye. Well, in my case, the right eye. And so some of those things have come back. I guess is what I want to say. Some of those things have come back, and so I've regained a lot of my movement, but my memory is where the challenge lies. And so you can imagine how that affects my life and ability to work and things of that sort.
Mm-hmm. What kind of work did you used to be a sports broadcaster? What kind of work are you able to do that still?
So I've doing that was something I did on the side. I've done broadcasted Royal men's basketball games, did color analysis for them for the past 5 years, and I did do some of those games. I don't think I was very good at it, quite honestly, but more especially, one of the things that was very frustrating to me was that while I was doing those games, I was unable to remember the players' names, and they would be right in front of me, and so there were some challenges that I hoped to work through, and I got through the broadcast, but I knew that I wasn't in good form, in good shape. Now, what I did primarily until June of last year was I worked at UIC, University of Illinois at Chicago, for 16 years in various roles. But the past 6 years, I've been the administrative director of telehealth. We started that program, and so I understood the benefits of telemedicine programs, telehealth programs, but more especially telestroke, and the ability to connect the patient with physician, especially since the amount of time that patient has is limited and fleeting.
Mm-hmm. I want to bring a couple more folks into this conversation. We're speaking with Stefan Robinson, as he said, a member of the planning committee for the Illinois Telehealth Law Forum. Previously, we've been speaking with Dr. Gurpreet Mander. He's the chief medical officer at St. John's Hospital in Springfield, Illinois. In studio with me is Harry Brockus. He's the CEO of Carl Hoopson Regional Health Center. He's the vice president of regional health for Carl. Thanks for being with us, Harry.
Oh, good morning. Thanks for having me.
Dr. Mander and Harry, both of you, as you're listening to this story, I wonder, Dr. Mander, if we could start with you. You said there were 20 hospitals, and it's an interesting thing as we're hearing Stefan's story because he was actually in the suburbs of Chicago, and I think in a way we think, well, if you're in the city, you have more access. And Dr. Mander, have you found that that's not necessarily the case?
Definitely not. I mean, access doesn't necessarily mean that rural areas will have worse access, and you see these issues in large cities too with some of the smaller hospitals. The Illinois Telehealth Network is, we are partnering with about 23 entities in southern and central Illinois, few of which are large medical groups to deploy shared telehealth services across the region. And stroke and acute care is just one element of telehealth. There are opportunities in behavioral health, which has already been mentioned by Nancy, because there's a big shortage of mental health providers, plus, of course, the stigma associated with that. But beyond that, there's also a shortage of various other specialists in most of our rural hospitals and some of our city hospitals, too, in underserved areas. And telehealth is one of the solutions which can be used to provide access to patients. But I think one need to understand that telehealth is not just about acute care. It's also about routine care. In fact, if you look at it, about 70% of your clinic visits to a doctor do not actually require you to be in the clinic, so they could be provided remotely. Same thing for urgent care visits, which is another program which one of our partner groups has launched, is to provide televirtual care, urgent care visits, where you can, if you have a cold or a cough, you can talk to a doctor, get evaluated, and see if it's necessary for you to go to the emergency room. So there are several applications of telehealth, right from the spectrum of an electronic ICU, which is 24/7 monitoring, to asynchronous, evaluation, where you can send a picture of a rash to a doctor, and he can evaluate and give you some advice. So, those are the various applications.
And Harry, as CEO of this regional health center, for context for folks, Carl Foundation Hospital is based in Champaign-Urbana. I understand that more than 90% of the 1.3 million patients that use Carl services live in rural counties. Is that correct?
That's correct. Everywhere from south of I-80 all the way down to the Kentucky border. our patients that we care for either in trauma events, because we're the only trauma center in this region, or in our NICU, which is our neonatal intensive care for babies that are born premature. So these types of services are very important to emergency rooms in those regional areas. Just like the example you've given with stroke here, I can tell you an example in Hoopston where we had a baby come with a simple rash, but the ER doctor really wasn't used to seeing it and wasn't sure what to do with the child, but we were able to use telemedicine to have a pediatrician come on the line, diagnose the rash, send the mom to CVS and get some cream versus taking a 2-hour trip.
And how often is that, and we heard Dr. Mander say this as well, it's not just for acute care, for emergency care, but also for routine care. How important is telemedicine to what you all are doing at Carle?
Oh, absolutely. It's a huge platform for us moving forward, and it's not just about routine care, it's about preventative care too. 3 platforms we utilize. Obviously, we use it in our emergency rooms with our Rural Alliance partners. We have 5 hospitals across the region that we partner with in emergency rooms to provide access to specialists during emergency needs. But just like Dr. Mander was saying, you can go to our clinics and see a neurologist, an endocrinologist, an OBGYN. It all can be done through a telemedicine connection for a follow-up visit. Let's say you came to Carle and you had a heart attack and you ended up having bypass surgery, but you need to have follow-up visits in the clinic after that. A little troubling to have to drive an hour to an hour and a half to get back over to the doctor's office just for a 20-minute visit. So we can actually do those visits right there, which increases compliance of the patient because they're likely to cancel that visit. It's an hour and a half away, more likely to go if it's in their local clinic. And then the other platform is e-visits, right? So we can actually engage the patient through a MyCarle platform where they can simply contact us on an e-visit and say, this is what's going on and I need some help. And that'll go to a doctor and he'll make a diagnosis within 4 hours.
And so that's through, when you say contact through an e-visit, that's sending an email or going into your website, or is it also actually even maybe doing a video chat or a conversation with a doctor virtually?
Right. Today our e-visit platform is based out of Epic, which is our electronic medical record. And you would actually go into your MyCarle website using Epic and go through there to send an email to the doctor. We're always working towards things like the instant doc on a phone type program. Those are the up-and-coming technologies. But I think even more important, Nyla, moving forward, is how we use this to prevent problems in the future, right? People who have cardiac congestive heart failure, they tend to gain weight quickly and end up in the emergency rooms with acute exacerbations because they're holding fluid in their body. There's actually technology out there now that we can put a scale in their home. That scale they weigh themselves every morning. The scale transmits that to their doctor every day. And the doctor sees a 5-pound gain in weight overnight. He knows there's a problem. The nurse contacts the patient and says, you've gained 5 pounds overnight. We maybe take an extra dose of medication. Or in some situations, we send somebody out to the house to give them a little extra medication.
And you're actually doing that right now?
We're not doing that now.
Okay.
That's where our plans are going.
That's
where our plans are going.
Before we get to the time frame for implementation for something like that, do you have a sense of what percentage of Carle patients are using electronic services like this now?
Yeah, we're up to about 50% of our patients are using a MyCarle account, so they're accessing their accounts through our MyCarle Epic Access. And we've only used about, in terms of e-visits, we've done about 140 so far this year. That number has continued to grow each year, and you'll start to see us market it more and talk more about it. And one of the things Nancy talked about that we've done with our e-visit platform is a lot of places, are concerned about whether their commercial insurance wants to pay for it.
Mm-hmm.
Well, in many cases, an e-visit, we just charge $20 flat fee. And that's really about the same as what your copay would be if you went to the doctor itself. So that's what you're going to pay out of pocket anyway.
And but that means it's an interest, if you're doing it that way, you guys are probably are you losing money on it? Or are you just thinking this is a cost-effective way to bring people into the system and you're going to recoup the costs in another way?
It's a cost-effective way to manage care. Doctors are a shortage in America. They're going to be a shortage in America for the next 20 years. Access to doctors and other providers is extremely prevalent. So if you have a simple condition that you can use an e-visit platform, that's great. It saves the actual office time for somebody who maybe has a more urgent, more timely need.
I'm speaking with Harry Brackus. He's the CEO of Carle Hoopston Regional Health Center. On the line with us from Springfield is Dr. Gurpreet Mander. He's with St. John's Hospital, where he's the chief medical officer there. And this is my question for both of you. And Dr. Mander, if you want to start, and then Harry, if you can weigh in. When you're thinking I'm thinking about particularly maybe older patients who may not be as used to, we heard Nancy saying earlier, for kids, from a mental health perspective, kids who have sort of grown up in a digital generation and FaceTiming and Skyping, it's a very comfortable thing for them to have a digital conversation with someone. Do you have, is there a lot of education, or is there resistance or work that you all have to do with maybe an older population that may not be as open to this?
Well, actually, we haven't seen that problem with our stroke network or our telehealth pathways. We found to be fairly receptive. Or no, you do need to go through an educational process for anyone, for that matter, who's going to be interacting with a doctor through a video conferencing or using, USB port attached ultrasounds or echoes. But patients adapt to that. I think what patients really like is having that one-on-one relationship with a specialist within a short period of time, gives them makes them more comfortable, gives them the sense that they're being cared for. We have not in general perceived that issue. And similarly with that teleheart pathway, which is similar to what was being mentioned, we've had a successful program through pericardiovascular for almost 14 years, called the Telescale program, where we do remote monitoring of heart failure. That has been an extremely successful program, and most of those patients are elderly and individual. So, the short answer to your question is no. But yes, you have to go through an educational process for anyone, for that matter, because it is a different way of delivering medicine. But as you see the younger generation, the millennials coming on, they are very comfortable with that, video interaction, and using electronic methods.
Harry, how about for Carl?
Yeah, I would say very similar response. Most of the time when we've had patients come in that are older, they get a little bit hesitant at first, but once they get in the room with the nurse and the doctor comes on the line and they realize that there's a digital stethoscope, there's a digital optoscope, so the doctor's seeing all the things he would see as if he was there in the room anyway, they get real comfortable real quick. And especially in the areas of mental health that Nancy talked about earlier, it has been the most successful program because people like that idea of privacy. They're not walking into a mental health center. They're kind of just going into a regular doctor's office and nobody knows why they're really there.
For Carl Foundation or for Carl Hospitals, Harry, I wonder how you've mentioned ways you'd like to see this expand. What are the biggest challenges right now for your expansion in doing telemedicine?
Right. Well, technologies are still developing, right? Some of the sensors that are being developed today are still very expensive. They're still not quite as accurate as you'd like them to be, but they're making exponential leaps every year. And I think over the next 5 years, you're going to see a dramatic movement to keeping patients more outside of the hospital than in the hospital. That's the way healthcare is moving today and being more preventative. The state just took on action with their mobile integrated health network, which is now going to allow non-emergent visits to the home by EMTs or nurses, which weren't allowed before. It's going to allow us to change the way we provide care and really be more proactive and building about community health. We're going to talk about community health in the future versus taking care of acute issues. And these devices like peak flow meters that can tell us when an asthmatic is having a bad day, glucose monitors that send a message to your phone and say your sugar is too high, and we send a message to your doctor. It's going to change the way we provide care. And it's an exciting time to be in healthcare because we're really going to talk about compliance and the patient's engagement and how they care for themselves.
And do you think this will really change the way we do rural healthcare as well then?
Absolutely. The access to this type of information is critical to making healthier communities in our rural areas.
We have less than a minute left, but really quickly, what else do you all need? What does Carl need to continue to do this kind of work?
Well, we need to continue to see legislative support for it at the federal and state levels. We need to see places like Blue Cross that Nancy talked about earlier jump on board and say we're going to reimburse for these types of things. That'll make patients more comfortable using them. And we just need more education. We need to get the word out to patients more and more.
That's Harry Brackus, Vice President of Regional Health for Carl Foundation, CEO of Carl Hupston Regional Health Center. Thanks to Harry as well as to Dr. Mander with St. John's Hospital in Springfield.
Thank you.
Thank you. Coming up, we'll be talking state politics in Springfield. Stay tuned. You're listening to The 21st.
The 21st is made possible by Kester & Bradley, LLP, providing legal services to the Urbana-Champaign community and Illinois residents since 1895. Kester & Bradley's attorneys are committed to achieving the best results for their clients. More information is available at kesterlawllp.com.